Yes.
Oh, thank you. I just know I'm a note taker.
I got it. I think that could belong here.
Hello and welcome to the Alabama Public Health Training Network. Thank you for joining us today for our program, Putting Insomnia to Sleep. I'm Kitty Norris, Assistant Chief Nursing Officer at the Alabama Department of Public Health. Today's program is produced and provided by the Alabama Department of Public Health, Health Media and Communications Division. The expected learning objectives of the program are to review the mechanisms and causes of insomnia in pediatric patients, to explain recommended treatment approaches for insomnia in pediatric patients as outlined by the AASM. The learner will recognize when CBTI or behavioral interventions may be indicated. The learner will understand core techniques of some commonly used CBTI or behavioral interventions in pediatric patients with insomnia. To discuss potential ways to integrate these interventions into general clinic practice and to review potential strategies for monitoring progress and managing treatment resistance for pediatric patients with insomnia. There is no commercial support or sponsorship for the program. There will be no endorsement of products displayed in conjunction with the activity. If you have a question about anything being discussed today, please call or email during our broadcast. The phone number and email address are on your screen now and will appear again later in the program. Also, the handouts, sign-in sheet, and evaluation are all available online. You will need to register for this program in order to access these materials. Continuing education credits have been approved for nurses and social workers for today's program. In order to receive credit for this training, you must watch the entire program, then complete and return the sign-in sheet and evaluation. No partial credit will be awarded. While content may continue to be relevant, CE credit will only be awarded for 2 years, expiring on April 17, 2027. If you are watching this program on demand and want to receive a social work CE credit, you will need to complete the social work test and send it in, along with your sign-in sheet and evaluation. If you are watching this program live, there is no social work test required. For social workers, if you are watching this program live, it qualifies for classroom hours. If you are watching on demand, it is considered non-classroom hours. Distance learning conference participants who are not employees, contract employees, or retirees of ADPH will pay a fee to receive continuing education certificates for this program. And now I would like to welcome and introduce our presenter as we get started. Dr. Mahini Gannett is a physician at the Division of Pediatric, Pulmonary, and Sleep Medicine at the University of Alabama at Birmingham. Welcome, Dr. Gannett. I know you have a lot of great information to cover, so let's go ahead and get started.
Thanks. I appreciate the opportunity to talk about insomnia today. It's something that we speak on frequently in our clinics, and so I thought it would be a good topic to review and hopefully provide some of our providers that are out in our pediatric practices and even adult practices with some information that they can maybe provide to their patients. So, moving forward. Some basic outline things that I'm hoping to cover. Essentially, briefly, just going to review some sleep basics, going into then the impact and evolution of insomnia. And then I'd like to kind of go over maybe a stepwise approach to how we can assess insomnia in clinic. And so how can providers, whether you're in primary care or subspecialty clinics, really approach some of the concerns that may be associated with insomnia in your clinic. Then, as mentioned in the objectives, a big part of this will be kind of reviewing some of the core concepts of cognitive behavioral therapy for insomnia, or CBTI. So somewhat of an, in a nutshell, presentation. And then, of course, at the end of the handouts, you will see that there are a list of resources and references that you're more than welcome to look into if you would like to incorporate some stuff into your clinics. So, just kind of bridging into some sleep basics. Ultimately, sleep can be very complicated, but there are some core principles that most people are probably familiar with. And essentially it's that during sleep we experience two different alternative types of sleep, and usually over roughly about an 8-hour period. And so we go through what we call non-REM sleep, or non-rapid eye movement sleep, and then rapid eye movement sleep. So non-REM sleep is composed of 3 different stages. So stage 1 is essentially a transition from wakefulness to sleep, and it makes up roughly about 25% of the night. Stage 2 is when you actually become disengaged from the environment, and so that's when your body temperature starts to kind of slowly downward trend. Vital signs are generally stable, but ultimately you're bridging from early stages of sleep into ideally deeper sleep. The combination of stage 1 and stage 2 make up about 50% of your night. And then you go into stage 3. Stage 3 is essentially one of our deepest parts of sleep. It's a very restorative component of sleep. So during this stage, you have a lot of relaxation of some of your vital signs. They start to slow down, and ultimately a big part of your energy and body restoration occurs during this stage of sleep. And then we transition into REM stage sleep. So REM stage sleep makes up about 25% of our total cycle of sleep at night, and it is when we continue some of the energetic and restorative features of our brain and our body. And ultimately, it's also when we have a lot of active dreaming. The rapid eye movements that occur during this stage is what makes up this stage's name, so REM, meaning rapid eye movement sleep. Your muscles become atonic, so everything in the body becomes very loosey-goosey is how we describe it. Ultimately, your vital signs are pretty irregular, but nonetheless, this stage is very important because it's one of the stages where memory consolidation and all are also very important. And so between the energy restoration and body relaxation, it's also to help with some of the memory consolidation that should occur in your body. And your stages of sleep essentially go through 90-minute cycles throughout the night over and over and over again. And they're balanced by essentially kind of a 2-process model. So this 2-process model, you can kind of describe it as process S, which is your sleep drive. So essentially, if you look at the chart, roughly around 7 a.m., when you wake up, your sleep drive is going to be pretty low. And as we're awake during the day, that sleep urge, or that tendency for us to want to sleep, that sleepiness, it rises. So this is essentially what makes us sleepy and sleepy and sleepier than come the end of the afternoon. So how long you've been awake really dictates how high that curve goes. And this is balanced then against the circadian sleep pattern, which is our process C. So this is like our wake drive. This is the natural biological clock in our body that roughly runs on a 24-hour pattern that goes between alertness and sleep. So in the morning, your process C tends to be increasing, so you're more and more alert. And then at some point in the day, it peaks, and then it starts to slowly downward trend. So at some point in the night, you have your process C at a very low and your process S at a very high. And so that tendency or that urge to sleep at that point is maximal. And that tends to be when people actually fall asleep. So one of the things about the process S is that the second you fall asleep, as you can tell from the graph, it's a very rapid decline in that pressure. So once you sleep, the pressure declines, and then roughly around the same rise time the next morning, you start that process over again. Naps and all that can also lead to a dip in that process S. So what kind of things can wreak havoc on this model? What things can really impact it and potentially either A, cause it to not be as in sync as it is, or what could happen if it's not in sync, what kind of outcomes can you have? And so insomnia tends to be something that is brought up in these clinics, and it is in fact a disruption or a dysfunction of this kind of in sync model. So the DSM criteria or definition really labels insomnia as a predominant complaint of dissatisfaction with sleep quantity or quality. And it's essentially when you have one of the following symptoms for at least 3 nights per week for about 3 months. And so that's with difficulty having sleep onset, nighttime awakenings, or difficulty with maintaining sleep, and or early morning awakenings when you in fact want to stay asleep. This difficulty sleeping should be present even if you have age-appropriate time and opportunity for sleep. So if you're given, for instance, an adolescent 9 hours of sleep opportunity, but they're having difficulty getting that, then that could be meeting that criteria. It should cause daytime impairment or stress for the child and or family. And so especially with little ones who don't necessarily understand that they have insomnia, it can, of course, cause impairment, though, for the family dynamics. And then it shouldn't be attributable to another disorder or condition. And my husband would validate that this is me, in fact, trying to sleep some nights. So insomnia can have various different types, essentially following that criteria from before, but initial insomnia being trouble falling asleep in the beginning of the night, middle insomnia being maintaining sleep is difficult, and or late insomnia, which is waking up too early. One thing to note is that insomnia is not defined by the specific hours of sleep a person gets or how long it takes to fall asleep. It truly can vary on how much sleep a person feels like they need or what type of satisfaction they have with the sleep that they get. So one person may be completely fulfilled and satisfied with 8 hours of sleep, whereas some other person may feel very strongly that 8 hours for them is too much and 7.5 is kind of that sweet number. And so ultimately it can vary by person, but it's, again, meeting the criteria of if you're dissatisfied with that sleep and having trouble with one of those stages of trying to go to sleep, maintain sleep, or waking up early with some daytime impairment. Another key feature, again, same key feature, I apologize, is really just that poor sleep causes distress. I don't know how many of you are at work right now, but I hope that this picture is not representative of those listening in to this presentation at the moment. So consequences of insomnia, they really are pretty varied and they're wide, but we see it a lot in clinic. And so unfortunately, insomnia can lead to a lot of discomfort in a patient and or their family dynamics, but it can also worsen underlying psychiatric disorders, prolonged medical illnesses. It really reduces quality of life. People really harp on bad sleep, and it really just impacts their mentality about the way they approach the day, potentially even the rest of their nights for the week, month, etc. It can lead to high absenteeism for work settings, school settings, activities. It can lead to increased accident risk, and this is important for our adolescent population and our adults. It absolutely is a cause of higher healthcare costs, and it can definitely lead to cognitive impairment. Difficulty with focusing in school, often misclassified or misdiagnosed as ADHD, can really just be poor sleep or insomnia that's not been properly addressed in a patient. The impact of it is well known, and providers probably are aware of this because they probably get these questions in their clinics. The estimated prevalence of it is roughly about 10 to 30% in the pediatric population. For those with certain conditions like autism, it's significantly higher and can exist as a comorbid concern in about 60 to 86% of this population. It's about 2 to 3 times higher than the typical neurotypical or developing youth. Unfortunately, not to anybody's fault, but unfortunately, there is a very low rate of diagnosis for sleep disorders in pediatrics, including insomnia. Several studies have been done and show that ultimately the rate can be as low as, for instance, 3.7% of pediatric patients diagnosed with sleep disorders at their well child visits, which is significantly lower than that estimated prevalence of 10 to 30%. Another recently published study did mention that over a 15-year period, that children that had insomnia as a child had persistence of those symptoms into adulthood. And so ultimately what this study was trying to indicate is that insomnia is not something that developmentally should remit. It is something that should ideally be addressed in childhood because it is frequently seen carrying forward into adulthood. And insomnia varies by age, and it can vary on how we then approach it, but some of the general basic understandings is that infants and younger toddlers may present very differently than adolescents. Adolescents and adults may present very similarly. Some elderly may present very much like infants and young toddlers. And so ultimately really gauging what their issues are may be more insightful, but in infants and young toddlers, we tend to see more night awakenings and sleep onset association issues. And this can vary based on their actual age. For toddlers and preschoolers, we tend to see refusal to sleep. I'm dealing with that now. Whew, it's a process. Night awakenings can be a problem, bedtime stalling and resistance, very common in this age group. And then again, continued sleep onset associations are also very common. Things like sucking your thumb, required rocking from the parent, or maybe some people drive in the car to help their kids fall asleep. I know that my mom used to tell me that she put me on a car seat on the laundry machine. So I guess that is very common in some of our elderly population when we were growing up. For adolescents, there tends to be a very large or higher rate of insomnia and sleep deprivation, so much higher in this age group compared to generally toddlers and adults, with decreased amount of adequate sleep and really a long time for them to fall asleep. In a sample of about 10,000 adolescents from one study, 2/3 of them reported that they had a sleep onset latency of greater than 30 minutes. It's a pretty large number of kids, and that they had a sleep deficiency of 2 hours. So imagine if you were not getting enough sleep, 2 hours of sleep per night for 5 nights of the week. That means in that week, you've lost 10 hours of sleep. So sleep deficiency is essentially just not getting that desired amount of sleep that makes you function well the next day per night. So a sleep deficiency of 2 hours really can be very impactful. Overall, these consequences can lead, or these scenarios can lead to consequences such as poor daytime attentiveness, their lower grade point averages, can be difficult to score well on tests, again, increased automobile accidents, risky behavior, higher rates of anxiety and depression, which is concerning for this age group that's already going through a lot and under a lot of pressure. And a lot of times these kids get called lazy, and it's really just that they're struggling to power through it because they're just not getting enough good quality or enough duration of sleep. So insomnia can kind of evolve. And the thought process is that there are predisposing factors, so things that are kind of unchangeable that may lead us to have an increased risk of insomnia. So things like lifelong characteristics, genetics, or sleep-like chronobiology. And so the presence of these may put you at higher risk of potentially developing or having insomnia. Precipitating factors are kind of think of them like your triggers. So things that may unfortunately trigger insomnia to occur. So they can be situational, they can be environmental. Say there's construction going on around the house, and so now your toddler, who normally sleeps at a very defined time, is struggling to fall asleep because now that environment is really preventing them from getting that sleep onset at that same time. It can be medical. You've developed GERD during pregnancy. It can be psychiatric. You're in a place of increased depression or anxiety, and you're just finding yourself struggling to fall asleep. Medications. Certain medicines, like for instance diuretics, can lead to nighttime awakenings. Some medicines lead to insomnia. So then this trigger fuels on top of the predisposing factors and reaches a threshold of causing some degree of insomnia, which then are fueled by these perpetuating factors. So perpetuating factors are essentially, if you think about it, behaviors or things that are maintaining the insomnia. So now you're in this vicious cycle where the insomnia started and something is keeping it going and you're struggling to get out of that pattern. So now this poor toddler who is hearing all this construction noise 3, 4, 5 weeks in a row struggles to fall asleep when the construction stops, maybe because they're scared of the noises. Now they're so used to staying up later, so then they stay up even longer. Maybe they get used to some type of thing that helped them fall asleep during those particular weeks that now they've developed an onset association with it. So for instance, mom used to rock the kid to help calm them down. Now they're dependent on the rocking. So there can be several things that are perpetuating that. And it's kind of depicted in the Spielman 3-factor model, which is essentially showing that, again, those initial predisposing factors exist, precipitating factors that can then push it above that clinical threshold for insomnia. And then ultimately, then there's these perpetuating factors that essentially just grow. Now you're struggling to get out of this insomnia pattern, and so those perpetuating factors kind of keep it maintained, and so then it's even harder to get out of. And so this is where people say, well, I've done it all my life. I've always fallen asleep with the TV and during bed. I've depended on sounds all my life. It's something that I can't get out. So these are where those kind of perpetuating factors lead to sleep issues. So those perpetuating factors are really the target for the cognitive behavioral therapy that we'll focus on here in just a little bit. So where do we start? So I think one of the things I was hoping to really review is how can any provider really assess insomnia? And so where do we start with the sleep history, and how do we look at the risk factors that may be associated? What are some comorbid conditions that we should be aware of? And then really, what are the components of a sleep diary, and how can we utilize that in clinic? Well, step one, a sleep history. Now, this is going to look long, and sometimes it can seem that way. But when you're naturally talking to a patient, you actually can address several of these questions pretty quickly. So let's start with sleep screening. So there's so many different ways that a provider can screen for potential sleep issues. In the adult world, there's several surveys that they use. Pediatric world, there's a handful of some validated surveys. All of them vary a little bit. So ultimately, what's the comfort and timing and what the provider has in being able to address it. But for instance, there is this acronym, I'm Up. So I'm Up really just quickly identifies, is there any difficulty with initiating sleep, I, difficulty maintaining sleep, M, unrefreshing sleep, U, or premature awakening, P. I feel like I fit all 4 of these categories with my younger one, teething. So ultimately, this can pretty quickly see if somebody is feeling like they're having some sleep issues. pediatric screening sometimes is a little bit more involved because they may not have as much understanding of those kind of 4 basic principles. Maybe there's more of a component of they're having trouble falling asleep without, say, the parent in the bed. Again, lots of surveys, but one that's commonly used is the BEAR survey. And this is a 5-domain survey that looks at common sleep irregularities, and that's bedtime problems, exposure to daytime excessive daytime sleepiness, awakenings during the night, regular irregularity in the duration of their sleep, and sleep disordered breathing. And depending on their age, the questions are tailored either to the parent or the child. And if there's difficulties in at least 2 of these domains, then those are kids that maybe need to be screened and assessed further and treated potentially for some type of sleep concern. This survey alone has been shown to double the likelihood that PCPs will identify sleep problems. So really tackling that low rate that's been shown in other studies when the prevalence is otherwise reportedly much higher. So as far as sleep history questions, now you screen them, what do you ask them? These questions can be, again, a lot. But again, if you're having just a conversation with these patients, you really gauge a lot of this in that conversation. So when is bedtime? And really emphasizing when does the patient physically go to bed and when does the patient actually fall asleep? Because those are 2 very different questions. Some kids go to bed at 7, but they don't sleep till 9, 9:30. And kids are pretty honest about when they go to bed. Parents, sometimes a little bit less honest. They think their kid is going to bed when they put them to bed. So it's good to ask the kid too when they feel like they fall asleep. What are they doing in the bed besides sleep? Are they watching TV, eating, listening to music, doing homework, reading? If they're reading, is it on a tablet? These are great questions to ask too. I have a patient who did gymnastics in her bed. Okay, different, but she really just felt like it was her mat because they couldn't get a mat, or she thought she couldn't get a mat at home. The second the mom heard that, mom went and bought a mat. Sleep latency. Again, how long does it take them to fall asleep? So this may be different than bedtime. Sleep position. Are they patients that struggle to sleep on their back? Maybe it just doesn't feel comfortable. Do they sleep with 5 pillows behind their neck? That may not be sleeping flat, so that could be indicative of something. Or do they really like to sleep on their belly? Then you'll have people that say, oh, I sleep upright in my recliner, and so that can be triggering. How many times are they waking up at night? And what are they doing when they do wake up? Is it just they wake up, they don't really know why? Choking, gasping? Are they having to go up to use a restroom? Are they eating? Time to fall back asleep. And this is a great question that really you just need to know, is it a few minutes or a long time? Because that kind of gives you, again, some insight on, are they taking a couple of minutes or are they taking hours? And then what's their rise time, wake time? What time do they wake up? For some kids, this might be what time does your first alarm go off and what time do you actually get out of bed? That can also be an hour to 2 hours. Total sleep time, rough estimate. Most people don't really know. Wake up feeling refreshed or groggy, meaning do they feel like they got good sleep in the night? How many naps are they taking during the day? I think this is a really important question because so many people will jump straight to none. But really when you ask them, do they nap on the bus when they're coming home? What about like that quick 10-minute power nap when they get right home and you're getting settled in the house and they just go lay down, they're on the couch. 10, 15 minutes may not be a nap to some people, but it can impact their sleep routine and they may not know it. And so when are the naps and how long are they? Are they napping in school? It's good to ask. And then caffeine intake. What types of caffeine? Is it a Red Bull? Is it a Starbucks coffee? Is it 10 Starbucks coffees? My colleague yesterday was joking that he's had 10 cups. It's quite excessive for his typical amount. He asked, is that too much? I said, it just depends on how much sleep you want tonight or the next night or the night after that. So, people have different intakes of their caffeine, but what type of caffeine? How much are they drinking? And what is their typical caffeine intake anyways? What about sleep environment? What does their bedroom look like? Is there a lot of light or is it dark? Is there a lot of sound around it or is it quiet? Is the temperature hot or cold? I like to sleep hot. My husband likes to sleep cold. It's kind of a problem for the both of us. Is there a clock around them? And is it glaring into your eyes? Do they sleep in their own bed or room? Or are they sharing it with siblings? And do those siblings have the same bedtime? Or do the siblings tend to be a little bit louder? Do they share rooms with their parents and the parents snore? And then what about pets? Pets seem innocent enough until they're crawling all over your bed or jumping around or barking when somebody drives by. And then it's important to look for psychiatric disorders. These can be very commonly associated with insomnia and difficulties with sleep. And so screening them, especially in a vulnerable patient population like kids and especially adolescents, is important. Are there any concerns for depression or loss of interest, anxiety, stressors, trauma, recent changes at home or school, recent life events? In recent life events, these things can be pretty simple. Moving to a new house, especially for a pediatric population, but maybe even for an adult. Something as simple as what we think is moving to a new house could be scary for them. Patient that I saw this week is afraid of the closet that's now in front of his bed that wasn't present in the previous home. He just feels like the closet is squeaky and has monsters in it. And that's a new fear that he developed with such a common life event or change. So how can these, components be playing into potential nightmares, fears, bedtime associations, etc.? And then part of that too is if they have any of these disorders, are they on any medications? So these disorders very frequently have medicines that can impact sleep quality, the stages of sleep we go into. It can make our sleep feel unrefreshed as a consequence of not getting enough deep sleep. They can cause insomnia. So some of the medications that are frequently dosed, they're commonly dosed at night, maybe they're causing issues for insomnia. So again, very important to gauge these things. And then what about potential sleep disorders that can be associated with insomnia? So by definition, insomnia should be as a consequence of several factors, but not attributable to another condition. And so you want to make sure you're screening for those because so many conditions can present with that daytime impairment and trouble with sleeping. So one of the commonly used surveys is an Epworth Sleepiness Scale, which is a series of questions that's scored with a score of 10 or higher, really commonly being a red flag, and saying that they're excessively tired during the day. Do they snore? And if yes, what positions are they snoring in? On their back, is it worse? Are they obese? So is there a risk of maybe some obstructive sleep apnea with associated choking, gasping, witness apneas? Are they restless? Restless leg syndrome can be frequently seen in all ages. For adults, they may be able to better identify kind of that burning or tingling sensation. For kids, they may not understand what that feeling is or how to describe it. So instead, you may see them kicking, tossing, turning. Kids that need massages of their arms and legs before bed or during the night. Sometimes looks like growing pains for some people. Oftentimes these are the kids too that may say like something's crawling on them. They feel like it's itchy. And so this can be very impactful towards being able to fall asleep appropriately or stay asleep. Parasomnias are commonly seen, and we talk about them often in clinics. Night terrors, nightmares, sleepwalking, sleep talking, head banging, sleep eating. Really, the list is endless. REM sleep behavior disorder, we don't see it as frequently or described the way that we typically would hear about it, which is kind of more violent or unusual movements. They're acting out their dreams. So somebody who is in the military who's now in their deep REM sleep who may be fighting a war and they're really acting out those motions and they're vocalizing it, but they don't know that they're doing so. Vivid dreaming, recall, etc. And then screening for things that can also cause daytime sleepiness like daytime disorders, so narcolepsy with cataplexy. So again, sleepiness with maybe some hallucinations at sleep onset or offset, some sleep paralysis, maybe with strong emotions, their muscles get weak. And so these are common symptoms that we would see for some of the common disorders associated with trouble sleeping, essentially insomnia. And in these cases, insomnia would be a secondary consequence of these potentially untreated, undiagnosed medical conditions. And then risk factors for insomnia. Again, their list is a lot longer than this, but common ones just being, was there a prior history of it? Any neurodevelopmental disorders that may place them at increased risk, such as autism, Asperger's, Rett's, ADHD, concurrent medical problems that are exacerbating it, that psychiatric concern, family and environmental factors. So are there stressors in the home that could be influencing their ability for insomnia or proper sleep? Lower socioeconomic status and/or vulnerable populations are at much higher risk for insomnia than others. And then for adults, very frequently we hear age greater than 65, female, and unfortunately those that have had changes in their marital status. And then moving forward with that would be a sleep diary. And if there's anything that I feel like providers could hopefully utilize a little bit more in their clinics for their own benefit of addressing some of these concerns during the clinics would be a sleep diary. It's essentially something that's kept for at least about 2 weeks or so. I usually advise maybe 4 to 6, depending on how much concern we have. It could, be upwards of 2 to 3 months. Just depends on the kid or the patient or the adult. But it really helps delineates variability in sleep from day to day. So I didn't get great sleep last night. I've got a toddler resisting bedtime a little bit. and a teething infant. I shouldn't say infant, she's a toddler now. But nonetheless, one bad night of sleep really isn't representative of my whole month. But for some people, they really can't see the difference. They just think they sleep bad every single day. And so this can really bring them some insight as far as what their actual schedule looks like. It also may help with identifying factors that are contributing to it. So what kind of things might be making insomnia present or worse, and what type of patterns are they, experiencing during the day and or at night that may be, keeping it going. So that in addition to really just, again, accurately perceiving their sleep. And so this is what an example of a sleep diary looks like. This is available at the AASM website, and it essentially is dated with indication of what type of day is it. So for instance, in the pediatric population, school day or a weekend. Is it a work day for some? Is it a holiday for others? And the diary starts at a certain hour, noon, and then goes towards night, which is 11 p.m. And ultimately, what you do is you shade in the boxes of when you are sleeping, and then you can mark it up in any other fashion or form that you'd like. So this can vary, and it just depends on what you're trying to explore, what you're looking into. I frequently ask patients to put things like EO for electronics off. I tend to have people put an arrow down for when they're going into bed, but then to shade it when they're actually falling asleep. If patients are on certain medications that I'm worried about could be impacting it, I tell them to write M for medications, but then I also just tell them they can write whatever they want. So whatever they think might be influencing their sleep, have them write it. Kids can be very engaged with this. Get colored pencils out, have them do it in different shades, different colors. They get really excited about that. Art activities are always a good way to engage people. Art activities also engage adults, just FYI. So ultimately, a sleep diary can be very helpful. There's electronic versions of this as well, but something about having it physically in front of you so that you can discuss it with them really goes a long way. And so I do encourage patients, even if they keep an electronic version, to consider really writing it down on the sheet of paper so there can be some visual activity when it comes to us discussing the outcomes and results of it. And so this is an example of one that I recently went over, a different style of the sleep diary, but essentially gives you the same understanding. So again, you see the down arrows for when they went to bed, up arrows for when they came up, and those are the black arrows on the actual diary, okay? And shaded in for when they slept. And on the left side of the chart, you see where they took some naps. And the diary was much longer than this. It was actually 2 months prior to this. But ultimately, I tried to just pick the one section that looked like a little bit more representative of what we tried to do and how it was impacting the sleep patterns. But you can see in the beginning that some of those days where we were taking naps were some of the days where maybe our sleep patterns were a little bit off. Additionally, on certain days, such as the weekend, when we were sleeping later, notice that in the mornings we were sleeping in longer, and so there was really no consistency. It was a little bit fluctuated. As a result, on some days where perhaps maybe they weren't able to sleep in longer, it would be some of those days where maybe the parents were complaining they felt sleepier and weren't necessarily engaged, and they were sleeping through soccer practice, and so they're very concerned that their kid has a daytime sleeping disorder, when in actuality it's probably just inconsistencies in their sleep pattern. And unfortunately, when you have so many inconsistencies, you can notice on the very right-hand side where the total number of hours are written, they're a lot less. So for a pediatric patient to be getting 5 hours, 6 hours, 7 hours of sleep, it's not exactly ideal. Now, notice after the weekend, with some discussion and talk, the concern was, let's try to have a more consistent rise time. So with consistency in the rise time and some decrease in the nap frequency, there was an improvement in being able to get to bed on time and actually falling asleep, because again, now that process S, or sleep drive, is probably nice and optimal, and it's not been depleted with your naps during the day. And so then the tendency and urge to want to sleep when you go to bed is a little bit higher. And so you can kind of see a little bit more normalization to that week compared to the prior week. And they sleep a little bit better overall. So notice that the hours that they're getting for sleep is also a lot better. So now what? Now you've done the sleep history, you've assessed some risk factors, you've got a sleep diary, and you're like, this person needs some help. What do? Lots of behavioral modifications, some cognitive behavioral therapy techniques that you can incorporate, review those medications, and when all else fails, and or at the beginning of the visit, doesn't matter, a referral to a sleep specialist. We're happy to see them. So what's CBTI and why? And in brief, it's really just a technique, a set of behavioral techniques to help kind of reshape the maladaptive sleep patterns and behaviors that we have and try to make it more positive and try to make it something that's also long-lasting. It's the initial treatment recommendation per most of the societies that monitor and manage sleep conditions, and really has been found to be very efficacious in managing sleep disorders, specifically insomnia. In several studies, it's been shown to be equally equivalent to an efficacy to sleep medicines, but in comparison to sleep medicines, it lasts longer. So while sleep medicines are kind of a temporary help, once those medicines are stopped or higher doses are not necessarily achieving the same effect, then you don't get the benefits of those. Whereas with cognitive behavioral therapy techniques, it becomes a lifelong habit. And so they're longer lasting essentially, and you don't have the side effects that you would with medicines. And then importantly, while cognitive behavioral therapy is very helpful and remains the first line recommendation, it does not help with treating those organic causes. So making sure that we're kind of assessing for those typical conditions that can make sleep worse. So there's 5 core components of CBTI, and I thought it would be good to kind of go over what these are. And majority of these are things that we do sometimes implement or go over to some degree, quite excessively, with our patients in clinic because they take time to address, but things that you could also implement in some of your practices to help some of these patients, especially with the lead time at our children's hospital being so long. These are techniques that some of these patients can be doing prior to coming to see us, and that may help when they're bridging in for other reasons. So let's address sleep hygiene. So sleep hygiene are really the set of basic foundational habits of good sleep. They are necessary. They're not sufficient to be able to improve sleep on their own, but they're still necessary, and they're a good start. So just making sure your bedroom's optimal. Is it quiet, dark, cool, comfortable? In my case, not too cool. Is there a lot of physical activity and exercise happening right before sleep? And how can we optimize that? Because you should have good physical activity and exercise, maybe a couple hours before bed to really help with the body energy winding up and then kind of slowly starting to settle down. And so making sure that we're incorporating that into our afternoon activity and at the right time. We want to limit noise distractions. So stick some earplugs in. Make sure that you're getting good sleep. If your partner snores, first have them go see a sleep specialist. Then use some earplugs. Avoid caffeine. So I don't know if you know this, but caffeine has a half-life of roughly about 5 to 6 hours. That means that after 5 to 6 hours, only 50% of that caffeine has left your body. So it can take anywhere from 12 plus hours for caffeine to leave your body. So I'm pretty concerned about my colleague yesterday who mentioned that he had 10 cups. Because ultimately, I think that caffeine's going to be sitting in him for a while. So, you want to make sure that you're drinking caffeine for purposes of enjoying the, not only taste and the warmth, but maybe some of the benefits of alertness. But you've got to be careful about the fact that it can last in your body for a long time. Limit fluid intake before sleep. Please don't have a jug of water right before you're going to fall asleep, only to have to wake up in the middle of the night and urinate. Don't go to sleep, though, hungry. Have a small snack, something that's not going to necessarily cause your reflux to get worse, but also something that's going to settle so you're not going to feel like an angry bear all night. Avoid napping after 3 p.m. For some people, this could be avoid napping on the bus. And so a lot of kids who are coming home at 4:30, and they're sleeping from 3 to 4:30 on the bus, that's really, really chewing into their sleep time patterns at night. The bedroom should be for sleep only. So everything else you do it outside the bedroom. Unless you're in college and the only place you have is your room, you really shouldn't be in your room all too much. And really in college, go do other things. Except avoid alcohol or smoking. And so whether it's in a pediatric patient that's unfortunately involved in these activities or in an adult, these can absolutely disrupt your overall sleep hygiene and quality of sleep. And so good sleep hygiene is not incorporating those ideally in your evenings. And then importantly, avoid electronics and screen time. Now, I feel like that's kind of the mommy side of me coming out, and people say, well, okay, whatever. You say that because you just don't want us on your phones or anything else. Well, why do we say that? Well, first of all, screen time has escalated like crazy. So We Are Social's 2019 Global StatShot showed that 5.11 billion individuals own a cell phone. It's estimated to be about roughly 66% of the world's population. That's wild. The United Nations estimates that more people worldwide have access to smartphones than toilets. I find that even more wild. Roughly 62% of patients spend more than 4 hours per day on their screens. Roughly about 29% spend maybe about 8 hours on their screens. That's an entire school day. That's essentially like saying somebody is watching or doing their school from the time that they wake up and go to school till when they get home on their screens. That's a lot. And what people don't realize is that screen time has its psychological effects, right? But it also has a physiologic impact. And this is where I think that some providers, if they have this understanding, this can be something that people, when they hear it, understand why we get concerned. And so here's the reason. Light moderates our circadian biological clock, our rhythm. So how does it do this? So essentially what happens is when the sun shines, no matter where you are in the world, so in China, here, Alaska, doesn't matter. When the sun rises, it has blue light wave frequencies that hit the retina cells of our eyes. Those retina cells, when they're triggered by that frequency, communicate through the suprachiasmatic nucleus, and so I just tell families a pathway, to a center of the brain is what I say. That center, associating that with the pineal gland, then suppresses melatonin secretion. And I ask kids, what's melatonin? And they say, it makes you sleepy. And I said, good. So if it's down or you're not getting it, are you going to be sleepy or awake? And they'll understand, awake. So the sun suppresses melatonin from being high, so therefore you're not as sleepy, and it does stimulate some of the hormones of wakefulness like serotonin through other mechanisms. Well, now the sun goes down, and those retina cells are no longer getting that trigger, and so they're no longer communicating through that pathway of the brain to the center of the brain that then says to stop melatonin. So now melatonin gets to rise. So at night, melatonin's stimulated, and it rises and rises and rises. Now, it doesn't rise immediately. It takes a couple hours. Otherwise, in wintertime, everybody would be falling asleep at like 4:30, right? Scary. But ultimately, people do start getting sleepy around 7:38. And that's because melatonin has now started to rise in the body to naturally bring you that sleepiness. And with your process as sleep drive, now you're just in a good place to sleep. Well, can we guess what has the exact same blue light wave frequency as the sun? And our brain doesn't understand at night that that's not the sun? Electronics. And have the kids and patients, adults, say that. And I swear, once we have that conversation, everybody in the room, including the parents, there's like a light bulb that goes off in the head, like, oh, okay. So now all of a sudden, they're looking at all these screens at night, and that blue light wave frequency is really triggering those retina cells, communicating with the brain to suppress melatonin. So naturally, their brains are not ready or secreting the right hormones in order for them to feel that natural urge or tendency to sleep. And it's very common that you'll hear that kids are looking at their cell phones or their tablets or their TVs until bedtime. And then all of a sudden they're sitting in bed and they're tossing and turning. And when you ask them, how long are you tossing and turning? They'll say 2 or 3 hours. You're like, how long did I say melatonin takes to rise? 2 to 3 hours. And so then it's just it's impactful. It's one of those things that if you kind of just explain that basic core component of how light really impacts it, they no longer look at screen time as you just kind of being the mommy figure in the room saying, no screen time at night. They more so look at it as there's a reason behind it. So sleep hygiene really should just be incorporated with a good bedtime routine. During fellowship, I heard this a lot from a colleague that I work with, and I just think it's the right way to say it. It should be a ritual. Your sleep hygiene and bedtime routine should really be a ritual that's consistent, same time daily, flows in one direction, ideally from the kitchen to the bathroom to the bedroom, kind of in that pattern, right? I usually tell patients, let's start your bedtime routine at dinner time. So usually everybody's around the table at dinner time. Maybe we're all watching a game, watching the Masters, whatever we're watching. But ultimately, after dinner time, your bedtime routine starts to kind of kick into gear, right? And you want to incorporate 3 to 5 activities, generally quiet, but low stim, kind of lasting anywhere from a few minutes to an hour. And those activities can be varied, anything. I advise parents to incorporate some chores for their kids, something easy, light, trash on 2 days of the week, maybe dishes on 1 or 2. My 4-year-old daughter likes to help me with the dishes. I don't know how helpful it is, but it's cute. I get some pictures. My husband likes to play chess against himself. I do some Sudoku puzzles. I'm not very good at them, but I try. My 4-year-old then likes to play with puzzles. My 16-month-old likes to terrorize those puzzles, but that's our routine. That's what we do every night, pretty consistently. And so that signals to the body that this is time to wind down. This is when our sleep is about to start happening. And I encourage families to consider some reward systems when they're trying to incorporate a good sleep hygiene or getting started on a healthy bedtime routine. Because it's really hard to change behaviors, right? So again, it's really difficult when we've been doing something for 30 plus years or 40 plus years or however long to now all of a sudden change. And that's even for kids who have just been doing it for a few months and sometimes for a few weeks. They really latch on to routine. So reward systems could be a good way to bridge that. Incentives galore. Everybody works towards that bonus if you have the opportunity to. So for example, you could do a pass program for kids. Ultimately, give them 1 to 3 passes. Those passes are for pre-approved activities, like you can get out of bed to hug a parent. You can get out of bed to drink a sip of water. You can get out of bed to use the restroom if they're in the process of potty training. Now, if they use those passes, that's fine. Once they've run out, they don't get up anymore. But if they save those passes, then in the morning they get a treat. You can have them pick from like a treasure chest. We have a treasure chest that has magnet tiles in it. So for every pass that she has, she gets one piece of her magnet tile kit and she can add it to her wall. And so these type of incentives, rewards really sometimes help the kids understand that there's a reason to incorporate this bedtime routine. And once you start doing those things and incorporating more and more, eventually you can grow away from the reward system. For some people, they have to carry it forever, sorry. But ultimately, the goal is to try to work on consistency. And once it's engraved and the body's entrained to follow it, then it becomes a lot more easy and a lot more natural. All right, cognitive therapy. So cognitive therapy is a little bit tough because it's ultimately looking to kind of correct a lot of the misconceptions that we have about sleep. So some of the beliefs that are not necessarily positive, but quite negative, in fact, and some of the attitudes that we have about sleep. So some of the people that feel like, I never sleep well, so what's the point? Or I've never been able to fall asleep on time. I am always going to toss and turn, right? Or I have never had my kids sleep through the night. That's just an unrealistic thing for me to even believe that that could happen, is them sleeping through the night. So these misconceptions can cause a lot of distress at night. And so cognitive therapy tries to aim at essentially making those negative Nancys a little bit more positive. So there's a lot of different thoughts that can kind of arise. They kind of fall into these categories over the next couple of pages. And not to go into too many of them since they're readily available for you, but ultimately providers can come up with some quick coping thoughts. And a handout could incorporate this too. It can be for adults to just read it and really incorporate that saying with them over and over and over again. It can be for adults to use with their kids to help them grow from it. But for instance, the all or nothing therapy, if I can't sleep 8 hours tonight, it's terrible. Maybe the coping thought is to reframe that. Every time I get even an extra hour of sleep, that is a good thing. Last night, it was pretty good that I got my 5 or 6 hours despite the teething. I was pretty impressed. I thought it would be less, right? So that can help kind of reshape that thought. Overgeneralization. Well, I didn't sleep well last night, so I'll never sleep again. How about I will try using one of my relaxation techniques to help relax my body and get better sleep tonight. What about disqualifying the positive? So although I slept well last night, it was probably just a fluke. Well, let's reinforce it instead with, I slept well last night and have been working really hard on this to get good sleep, which means that something's working. Fortune telling. I just know that tonight's not going to be another good night. It's going to be a bad one. Here we go again. All right, let's try to do some more logical thinking. I can't really predict the future. Who knows what tonight's going to look like? So worrying about it may not be helpful. We'll just see what happens when it comes. What about the mind reader? No one understands what it's like for me to cope with insomnia. It's just me. Only I know. Well, let's try to see if we can find an exception. I'm not the only one who has this insomnia. I don't like it, but I'm working on it. For some, maybe I work on it with somebody else in my family that's struggling with it too. And these are, again, additional thoughts, and you're welcome to read them through. But the goal would be to try to provide them some coping thought to kind of directly reinforce over and over and over again. And so you do these naturally for other problems in life, other medical conditions, etc. Sleep is no different. What about somebody who's a worrier? So we discuss this a lot in clinic, and it's essentially using worry time to help with some of the poor concerns or things that may disrupt our sleep. So people that tend to have anxieties or thoughts that come in the middle of the night that worry them or bother them cause increased anxiety. And so the goal is to try to reduce those from occurring during sleep and instead shift them to occur during the day when we can address it. So I thought this was a really cute box that somebody made for their worry box, and the tag says there, "Feed me your worries." Pretty adorable. But similar protocol that I use in my clinic is first, set aside a daily time. I tend to tell people it's okay to incorporate this in their early bedtime routine. If it's something that's going to cause more anxiety, then maybe earlier in the day, perhaps like for instance when they get home from school. And so you'll have initially 2 bowls, one bowl with a bunch of empty slips of paper, and a second bowl that at the beginning will be empty. And what the person does is they take one slip of paper and they write down a thought, a concern, a worry. Okay, so for mine it might be, fill out the daycare registration forms. And then I'll put that slip of paper into the empty bowl, and then I'll get another slip of paper. pick up the dirty diaper that I saw in the bathroom that I still haven't got. And so something that you should probably go do and just don't do it. Isn't that silly? But ultimately it bothers you. You think about it. It's nagging at you. And then in the middle of the night, all of a sudden you wake up. Did I get that dirty diaper off the floor? Oh no, go get it. It's going to smell. Hopefully a lot of people aren't throwing dirty diapers on the ground. We're in a potty training session. So sometimes it happens. But ultimately you need a way to put that somewhere so that you know that it's going to be there. And you put that again in the bowl. Now, the next day you come to it at your designated time. So, for instance, for somebody that might be at 5 o'clock. And so at 5 o'clock, they'll come to their bowl. And what they'll do is they'll go to the bowl with all of the different tasks and they'll pick one. All right, this one says, pick up the dirty diaper. All right, Mohini. So you go do it. You go walk over, you go get that, you throw it away. Now you come back to the bowl, you take that slip of paper, tear it up and throw it in the trash can. And that's key. You've got to show your mind that you've done the task and that you're done with it. It releases it from your mind. You don't worry or stress about it anymore. And then whatever time you've allocated to this session, so if you do this for 15 minutes in your day or an hour, just depends on the person, you go through whatever slips or however many slips you can. Say one of them is 2. I need to write the introduction to my history paper. I don't have time for that today, so I'm going to put that right back in the bowl. Okay? So again, then at night, so if somebody has a history paper due, say on Friday, they're not thinking about it every night because they know that in their worry bowl it's still there. They'll address it when that time comes. So the goal is for people to relieve the thoughts that would generally otherwise wake them up and nag at them at night into a space. And when you incorporate it into your routine, it reassures your mind that you will have a set time the next day to address that worry. Cognitive restructuring is also really important and similar to probably what we try to do as parents when our kids are growing up, but it can be relevant to anybody. It's really just addressing, for instance, like a child's fear before bed. So say they're afraid of the dark. Teach them some brave self-talk, coping statements like we talked about before. But parents can also incorporate, like, for instance, creative gameplay at bedtime. So play flashlight treasure hunt. Do something that they can enjoy or look forward to that now incorporates that fear and restructures it to not be something that they're afraid of, but instead are familiar with. For kids that have special needs or autism, restructure the way you approach them with more visual things that can actually help them regulate the way they're feeling because they can now visually see it. Things like nightmare disorders, try imagery rehearsal therapy. So this is essentially taking a situation and generating a new ending and discussing it over and over and over again. So for example, if a kid, an adolescent, says that they feel like they're dreaming constantly about being chased, well, let's reshape that. Let's make it that the person chasing them is her mother and she just won the lottery. That's great. And that sounds silly, but when the kid says it over and over and over again, now all of a sudden, that nightmare that they had, they do start to kind of think of that. And so the person chasing her will start to look more and more like her mother. And unfortunately, she will have won the lottery only to wake up to know that she hasn't, but perhaps the lottery in her case would be that she's no longer having this bad dream. Now we're on to stimulus control. So stimulus control is essentially learning to associate a situation and a condition response, and trying to associate the two to be what we would want or in favor of it. So in the broad scheme of this talk, it's to try to help for insomnia, the bed to be associated with sleep, not with other things like worries, anxieties, wakefulness, tossing, turning, etc. So it's based on, Pavlov dog theory. So if you have an unconditioned stimulus, like in the picture, so for instance, food, now you have another situation, a bell, that doesn't really stimulate anything for the dog. The dog just hears it. But say you were to ring the bell every time there was food present. The dog's going to start drooling because they see the food, and in the background they're hearing the noise. Well, eventually, if you do that enough, now when they hear the bell, they're going to associate the bell with food, and they're going to drool. So it's a very similar concept to bed. If you're in bed tossing and turning for hours, eventually your brain thinks it's okay for you to be awake in bed. So it doesn't have the desire or the association to sleep in bed. So the goal is to basically condition yourself to only associate bed with sleep. So don't use the bed for anything else. Only use it for sleep. Not tired, not to relax, not to read books or do your homework. I mean, in college, I felt like I did everything from the bed. Not great. Not a good way to go. You definitely want to do those type of activities on the couch outside in the living room or in a specific space meant for work. But for bed, just sleep. When you're not sleepy, get out of the bed. though you shouldn't be glaring at a clock, people can generally tell when they've been tossing and turning for a long time. So essentially, if you're not sleepy, get out of the bed and go to another room, dim light, couch, quiet environment, and do something very low stimulation activity. For me, back in the past, that used to be reading my organic chemistry textbook. And lo and behold, the second I feel sleepy, thankfully after a couple of minutes, I would go right back to the bed and try again. Now, if I tossed and turned over and over and over again, I'd do the same thing. I'd get right back out and go right back to that situation where I would read a book, usually organic chemistry, and go right back to the bed. And over time, initially you might be doing that a lot, getting out, going back, getting out, going back, but over time, your brain starts to understand that you only go to the bed when you're sleepy and sleep. And therefore, it'll become lesser frequency of you having to get out, because eventually you'll start sleeping when you actually go to the bed. And to help with your stimulus control, you want to make sure you're rising at the same time and that you're avoiding naps to help with the circadian pattern, the regularity of it, and maintaining that homeostasis that we talked about earlier. All right, sleep restriction. So this is another core component of CBTI. And it's one that more commonly is done with a sleep psychologist or with a board-certified sleep physician. But the concept can be applied in some basic ways in the outpatient world as well. And really the goal is similar to stimulus control and associating the bed with sleep, but also reducing the time that we're spending in bed to truly just when we're sleeping. So it's not to decrease sleep, but it's decreasing time awake in bed. So the way you kind of approach this is you want to assess how much time they're awake in the bed and then match their actual sleep time to their sleeping patterns, and then eventually gradually increase that. So let me explain that in a different way. We assess it with what we call sleep efficiency, SE. So what you do is you take the time that they actually sleep, and you can gauge this on that sleep diary, right? So the arrow when they go to bed to when they actually shade it in, and the arrow to which they wake up. And then their time in bed. So for somebody, for instance, that sleeps about 5.5 hours of the night, but they're in the bed for 9 total hours, their sleep efficiency is 61%. For somebody who, when they get in bed, they sleep 7 hours of the total time that they're in bed of 7.5 hours, their sleep efficiency is much better at 93%. So what you want to do for sleep restriction is the goal is to try to have higher sleep efficiency. So if you find that they're having really poor sleep efficiency, you start with limiting the amount of time that they're in bed. And again, you're not limiting how many hours of sleep they're getting, you're just more mimicking their actual patterns of sleep. So if you look at this graph, you can see that the baseline patient with insomnia has white boxes, which are their wake times, and then the gray boxes, which are their sleep. So notice that they're wake, sleep, wake, sleep, wake, sleep, wake, sleep. Now, if their desired rise time is 7 a.m., okay, you want to try to find, based on how many hours that they need, a time that they can go to bed to meet their 7 a.m. So in the case above, they're getting about 5 hours of sleep overall in their baseline insomnia. So for week 1 for sleep restriction, you tell them not to get into bed until 2 a.m. Now, from 2 a.m., now their urge and sleep drive is really high. Hopefully they've not taken naps, that would defeat the purpose, but the goal is when they sleep at 2, they're actually sleeping that 5 hours to 7, they wake up. Again, not taking away the sleep that they were already getting, but more so condensing it all at once. Now their sleep efficiency is a lot better, so they're getting better sleep overall. So then what you do is after they've been getting good sleep like that for a few days, you back up a little bit. So make their bedtime 15 minutes earlier. 3 or 4 days later, go back another 15 minutes. And eventually you keep going back on that time until the total amount of sleep that they're getting is now the recommended total amount of hours that they should be getting. So that varies for every person as well, but for certain kids, it can be anywhere from 10 to 17 hours. For adolescents, roughly around 9 hours. For certain adult populations, usually about 7 to 8. And so that's how you kind of get them to now optimize their time in bed. They're having a little bit more better stimulus control, classical conditioning, and then ultimately that sleep restriction is helping them understand to condense all of their sleep and then gradually go back towards their desired bedtime. Sleep compression is a similar process, but more gentle. Instead of all of a sudden going from, say, a previous 10 p.m. bedtime all the way to 2 a.m., you would take the amount of time that you would need to decrease it to and just kind of gradually do it over the course of several weeks. So if they're spending 5 hours in the bed awake, then maybe week 1, you would have them sleep 1 hour later. Week 2, 1 hour later. Week 3, 1 hour later, until they're at that condensed spot, and then gradually go backwards. It's a little bit easier so that people aren't all of a sudden losing 5 hours of bedtime and having excessive daytime sleepiness is how some people feel. This also applies to bedtime fading though for kids. So the concept is the exact same. Those kids that are taking a lot longer to sleep, maybe they're just in that resistance mode, like my daughter. You want to then match their current bedtime to maybe when they're actually more naturally falling asleep. And so, for instance, in our case, that's about an hour later than our typical 7:30 time. We're seeing that where she's more sleeping closer to 8:30. So then we mimic that 8:30 time. And what we'll do then is every few days, we gradually fade back till we get back to her 7:30. That way her body is not having all of those other conditions working against her. And we're maintaining her stimulus control and then not restricting, but ultimately mimicking what her natural pattern is, and then gradually helping her circadian rhythm understand that we are trying to achieve that full amount at 7:30 start. So what can we do to help implement this in clinic? Ultimately, really having consistent patterns. It's really hard to work towards getting a better pattern if you don't have a consistent pattern. So get out of the bed at the same time every day. Again, reduce the amount of time you're spending in bed that's awake and make it match when you're actually sleeping. Don't get in bed prior to that. So if you have a bedtime based on when you actually fall asleep and when your desired amount of hours of sleep are, maintain that. Limit naps. Ideally nothing after 4. Maybe nothing that's longer than 45 minutes, because then your sleep drive, like I showed you earlier, that process S really just plummets. There's kind of this half hour rule. Just sometimes people need numbers. So if you're lying in bed for about 30 minutes and you can't fall asleep, tell them to get up, go do your quiet time activity for about 30 minutes, and then try to return back to bed, or earlier if you're sleepy. And then last but not least, relaxation therapy. So relaxation therapy is sometimes a fun one, but sometimes it is hard for kids to really understand the mechanism. So I usually advise them to look up some videos on YouTube. There's also some apps that can kind of go over these techniques, but it's just the concept of things like diaphragmatic breathing. So having them learn how to breathe with their belly and focusing on when they breathe in and breathe out, the belly moving out and in. And then progressive muscle relaxation. So helping them focus on different muscles of their body and honing in on relaxing those can help them not think about other things or other worries, and ultimately can help them actually relax their body to be able to then fall asleep. Imagery. So guided imagery is essentially like an audiobook, hearing a pretty scene of the beach or a nice walk down the park that you just hear over and over and over again, and you know that image like the back of your hand, and you just say it over and over and over again in your head, and you think of that image, and eventually that image helps you fall asleep. Try not to have it have any type of stressors, like poor Humpty Dumpty over here thinking about the sheep that are jumping over the wall with him. Not ideal for him and the outcomes that we know unfortunately exist for him. So you want the imagery to be something really truly peaceful and something that you enjoy. And the goal is that relaxation training can be used, with the other techniques as well, and ultimately should be relaxing. Now, what about meds? Medications are actually not the first line therapy for any insomnia, whether it's for the pediatric population or the adult population. And in the pediatric world especially, there's no really FDA-approved medication therapy for treatment or management of pediatric insomnia. There are some patient populations that there's maybe an indicated role for, say, instance, like melatonin. In the neuroatypical patient population, there's been several studies to show that can help with some of the sleep sedation and circadian rhythm dysfunction that they may face. Some of that dysregularity can cause this imbalance in their melatonin secretion and hormone balance at night, and so therefore they may benefit from some melatonin. But ultimately, medication shouldn't be first-line therapy, and it's tough because people want an immediate fix. And sometimes part of the process, including in our clinics, that we just have to explain to patients is that sleep is something that we value and should be an important part of what we do and how we incorporate our routines and lifestyles every day. However, when it comes to fixing it, it's not something we can fix overnight. It's something that can take several days to weeks to months to sometimes years. And it's all about how much effort we want to put to try to achieve that better outcome. And so in summary, I do believe that screening for insomnia is very important. And unfortunately, there's just not enough time in a well child visit sometimes to address it. And so for some reason or the other, it's good to maybe include some of those surveys so that you can maybe screen for them a little bit better, so that maybe follow-up visits can be incorporated to help with addressing that one specific concern. Education can be impactful. Again, tell them about the way that light impacts melatonin. It can go a long way. Screen time is something everybody's doing. And so even for parents who are actively sitting there on the phone when I'm talking to the kid, all of a sudden that phone goes down. And so you just really see the impact of education on those kids. And when they come to our clinic and they're hearing that education for the first time, sometimes they're soaking it in, but it's a lot of information. So when they've heard it over and over and over again, it really can go a longer way for them. Good sleep history gathering with the initial screening and then really keeping a sleep diary can also go a long way. And it can really help with providers identifying initial areas of concern to address early. And again, with lead times being so long for majority of subspecialties, just because of the high volume of patients that we're good identifying, we want to see if we can try to provide them with something to do while they're bridging into those specialties. Sleep hygiene is important. Again, it's not the cure-all, and it definitely cannot be the only thing that we use, but it's a core component of really addressing some of the issues, and it could be a great first start. And so helping them really learn habit of a healthy bedtime routine. And then lastly, formal CBTI, while it should be done with certified sleep providers, it is gold standard management and by all means can be incorporated in various different ways in pediatric and or adult clinics and should be something that if a provider is able to, should be something that they could tailor somebody's sleep concerns to with starting some of those techniques early, and then we're happy to help fine-tune it when they do bridge into our clinics. And that can help them also understand the importance of starting somewhere in order to help overcome some of the barriers that they might face as they're kind of making their sleep habits better. There's several resources. I've included them just to help people kind of gauge, but there are so many to list. But some of the more referenced sites, as well as the AASM accredited sleep center site, can help you identify where to find a accredited center to get some of these therapies, where you can find perhaps somebody that's board certified in behavioral sleep medicine to help with CBTI. There's also several books that patients can read. I think it's funny to read insomnia books to help with your insomnia. And so again, just the component of how can we address people and educate them and empower them. There are mobile apps. There's a great one called CBTI Coach. It has all this information embedded into the app. And so I do encourage patients when they download it, look at it, read it, kind of see what some of those techniques are. It has guided imagery already built in, so you can just hear the voice. It teaches them what type of imagery techniques to use. Lots of internet sources and programs that people can look into that help with kind of more formal coaching and training. Et cetera, et cetera. And then my references aren't few. There are many, but there is a lot of effort and push to really educate patients on this topic, given the high prevalence of it in both the pediatric and adult world. And so appropriately, lots of studies that go into trying to help with screening and diagnosing as well as management of insomnia in this patient population. And that's what I have.
That's great. That was very interesting and informative. So we thank you. This concludes our program for today. We want to thank you for being our presenter and for being here with us and allowing us to watch and learn from you. If others have questions, can they email those for some
Happy
answers?
To address them.
Okay. So just email to the address that was on the slides, and we will try to get some answers back to you. Thank you very much.